Hello friends, welcome back to our channel. In the last video, we have completed the introduction and pathogenesis of rheumatoid arthritis. Now let us move on to clinical manifestations of the rheumatoid arthritis. So there are both articular and extra-articular manifestations for rheumatoid arthritis. So let us go one by one. Okay. So articular manifestations, they present as chronic inflammatory symmetrical peripheral polyarthritis. Okay, so they're for chronic time, and they're inflammatory in nature, and they're symmetrical. And by symmetrical they mean that if there is a problem in the right metacarpophalangeal joint, there might also be a problem in left metacarpophalangeal joint. Okay, so peripheral, they mean the small joints which are present in our hands and in our legs. Okay, so polyarthritis, they affect more than one joint. Okay, this is what they meant by present. They present as chronic inflammatory symmetrical peripheral polyarthritis. Okay, so mostly they involve the small joints of upper limb. Okay, the joints that are involved we'll discuss the joints that are involved in upper limb, lower limb, and axial skeleton. Okay, so in the upper limb, they most commonly they involve proximal interphalangeal joint. Okay, so we have three phalanges, right? um, Proximal phalanx, middle phalanx, and the distal phalanx. Okay, so the joint between the proximal and middle phalanx is called as proximal interphalangeal joint. Okay, and the joint which is in between the middle and the distal phalanx is known as distal interphalangeal joint. In rheumatoid arthritis, most commonly this proximal interphalangeal joint is involved. Okay, and there are metacarpals over here. There are metacarpals over here which will join the proximal phalanx. Okay, so the joint here is metacarpophalangeal joint. Okay, the next joint that is involved is metacarpophalangeal joint, and the other joint is elbow joint. Okay, there are three common joints. They are proximal interphalangeal joint, metacarpophalangeal joint, and elbow joint. Okay, and there are few joints which are spared in the upper limb. They are distal interphalangeal joint. Distal distal interphalangeal joint is spared, and also the first carpometacarpal joint. It means a thumb. Okay, so the down the thumb, so where there is metacarpal and we have carpal bones over here. Okay, so the first carpometacarpal joint is also spared. Fine, so these are the two joints that are spared in rheumatoid arthritis. One is distal interphalangeal joint, and the other is first carpometacarpal joint. Okay, in lower limb, there is involvement of fifth metatarsophalangeal joint and knee joint. Okay, so in lower limb there is involvement of fifth metatarsophalangeal joint and knee joint, and in the axial skeleton, there is involvement of C1 and C2 spine. As we know, other than C1 and C2 spine, they come under synovial joint, and all other vertebrae which are other than C1 and C2 vertebrae, they come under uh, am, amphiarthrosis. Okay, so these are the only thing which allow a slight movement. So there is a this is a synovial joint, so there is a synovial fluid here, and in other vertebrae these are not synovial joints, so there is no synovium present here. Okay, so the all other vertebrae other than C1 and C2 gets paired. Okay, so these are the main articular malformations, articular manifestations. Now we'll move on to deformities. Okay, so mostly there's involvement of proximal interphalangeal joints and metacarpophalangeal joints, right? This is just a diagrammatic representation. Okay, please check it over here. So now let's move on to the deformities. Okay, these deformities, they are reversible deformities and irreversible deformities. Okay, so first let us deal with reversible deformities. The most important reversible deformities are zigzag deformity, piano key deformity, Hitchcock's thumb. Okay, So in zigzag deformity, the wrist will have radial deviation and metacarpophalangeal joints will have ulnar deviation. Okay, and there will be extension of interphalangeal joints. You can see this. Okay, here this is okay, there is a radial deviation over this side and there is an ulnar deviation over here. Okay, wrist is deviated towards radial side, and the fingers, the phalanges, sorry, metacarpals and phalanges, they are deviated towards the ulnar side. Okay, so this is what he meant by zigzag deformity. You can see there is zigzag deformity. Okay, so this is your zigzag deformity. Next comes piano key deformity. So there is a ulnar collateral ligament. In piano key deformity, there will be rupture of this ulnar collateral ligament. Okay, so this rupture will cause deformity in the ulnar styloid process. Okay, um, with piano key deformity, there will be rupture of ulnar collateral ligament, which will cause deformity ulnar styloid process. Okay, next comes Hitchcock's thumb. This is a Z-shaped deformity. In this deformity, there will be abduction and hyperextension of thumb. Fine. So we'll see right now. This is our Hitchcock's thumb. Okay. So there is abduction of the thumb and there is hyperextension of the thumb. Okay. Abduction and hyperextension of the thumb. This is known as Hitchcock thumb deformity. So these three come under reversible deformities. Okay, the zigzag deformity, piano key deformity, and Hitchcock's thumb. Fine. So after reversible deformities, we have irreversible deformities. They are swan neck deformity, botanist deformity. Okay, so these are just opposite to each other. In swan neck deformity, we'll see hyperextension at proximal interphalangeal joint, and we'll see flexion at distal interphalangeal joint. Okay, let us now see by diagrammatic representation. So this is a swan neck deformity. You could see like this. Okay, this is a swan neck deformity. Fine. So there is hyperextension in proximal interphalangeal joint, and there is flexion at distal interphalangeal. This is flexion of distal interphalangeal joint. Okay. So this is our swan neck deformity. So you could see this. This is also our swan neck deformity. Flexion of distal interphalangeal joint and extension of our proximal interphalangeal joint. Okay. Now let us move on to another irreversible deformity, that is botanist deformity. In botanist deformity, there will be flexion at proximal interphalangeal joint and hyperextension at distal interphalangeal joint, just opposite to our swan neck deformity, right? In swan neck deformity, there was hyperextension at proximal interphalangeal joint and flexion at distal interphalangeal joint. When you come to botanist deformity, there is a flexion at proximal interphalangeal joint and hyperextension at distal interphalangeal joint. Okay, so we'll just see. Yeah, this is our botanist deformity. You could see upward movement of this is the extension of distal interphalangeal joint. Okay, in swan neck deformity, we have, see, this is the difference. This is swan neck deformity. We have flexion of distal interphalangeal joint, and this is extension at distal interphalangeal joint. Okay, these are the deformities in hand. In hand, we have reversible and reversible deformities. Reversible deformities are zigzag deformity, piano key deformity, Hitchcock's thumb, and in irreversible, we have swan neck deformity and botanist deformity. Okay, so in lower limb we have deformities of hammer toe, forefoot varus, and pes planus. Pes planus is nothing but flat foot. Okay, so yeah, these are hammer toes. Okay, these are hammer toes. See, this is a proximal interphalangeal joint, so they move like this. So these are the hammer toes, and this is pes planus, which means flat foot. Normally we have an arch But in pes planus we lose that arch. So in rheumatoid arthritis also we lose the arch and there is a formation of pes planus. Okay, so these are the deformities we see in both upper limb and lower limb. And in upper, okay, we have also seen the reversible and irreversible deformities. Fine. So we have seen the articular symptoms. Now let us move on to extra articular symptoms. Okay, as we know that these symptoms are produced by the cytokines. Cytokines, they don't merely get restricted to the joints, but they move freely and reach the multiple organs. This cytokines reaching the multiple organs will cause the extra articular symptoms. Okay, so when they reach brain, the cytokines act as pyrogens, okay, which may cause fever, fatigue, loss of appetite, and weight loss. Okay, when they reach uvea, it will cause uveitis. When it reaches sclera, it causes scleritis. And this is an important thing when there's a formation of rheumatoid nodules in the skin. Okay, these are just like some bump-like structures. When we take it for pathological investigation, we will find the fibroid necrosis in the center, and these palisading histiocytes will just surround them as a fence. Okay, if we have fibroid necrosis like this, like this, these palisading histiocytes will surround them as a fence. Okay, we see this in the um, pathological investigation. Okay, so these rheumatoid nodules can be singular, can be multiple. Okay, these are just subcutaneous nodule. Okay, they're palpable. On palpation, they're firm, they're non painful, there'll be no tenderness, and these are usually present around the affected joint. Okay, so if there is a rheumatoid nodule over there, uh, we could guess that that underlying joint may have undergone change in rheumatoid arthritis. Okay, there is an inflammation around the joint, then the rheumatoid nodule has formed over there. Okay, we could suspect that. And it could also affect blood vessels, which may cause vasculitis. Okay, uh, when there is vasculitis, those vessels are prone to develop atheromatous or fibrofatty plaques. Okay, these atheromatous and fibrofatty plaque will narrow down the blood vessel. Okay, which may lead to ischemia, and the patient might also land in myocardial infarction of heart. Okay, there may be myocardial infarction uh, in rheumatoid arthritis because of this vasculitis. Okay, so when they reach the lung interstitium, they cause fibroblast activation, and this fibroblast activation might cause pulmonary fibrosis in the lung. Okay, and we know about Kaplan syndrome, right? So when there is pneumoconiosis associated with rheumatoid arthritis, we call it as Kaplan syndrome. Okay, when these interleukins reach the liver, they cause the elevation of the hepcidin. Okay, this hepcidin will cause a decrease in the serum iron, which will lead to anemia of chronic disease. In any chronic disease, the inflammatory markers will go and causing elevation of the hepcidin, which will further decrease the serum iron and lead to anemia. Okay, next, let us discuss about spleen. There is one important syndrome called Felty syndrome, which is seen in rheumatoid arthritis when the rheumatoid arthritis is in association with neutropenia and splenomegaly. Okay, when splenomegaly, neutropenia, and rheumatoid arthritis are together, we call it as Felty syndrome. Okay, uh, so this may affect this rheumatoid arthritis. Interleukins can also affect lacrimal glands and salivary glands and cause destruction of their epithelium and lead to secretory cell loss, which causes decreased secretions of the lacrimal gland and salivary gland. Okay, that may cause dry eyes, dry mouth, right? So it is considered as secondary Sjogren's syndrome. As we know, secondary Sjogren's is always associated with either with rheumatoid arthritis or SLE or scleroderma. Okay, so these are the extra articular symptoms. Okay, we have completed the extra articular symptoms along with the deformities. Okay, these are the clinical manifestations of rheumatoid arthritis. The notes are available in our Instagram channel. please go check it out. Please do like, share.